Okay, good morning everybody. So I'm going to discuss the role of the respiratory muscles in the development of villi, or actually, can we prevent villi by reducing respiratory muscle strength? So these are my conflicts of interest, nothing really related to this talk. And just one slide about villi, because we have a state-of-the-art talk on this subject tomorrow, but to me, villi is the result of high tidal volumes generated by the ventilator, or actually high transpulmonary pressures that induce a bit of injury. And this injury in the lung induces an inflammatory cascade which further exacerbates lung injury, in particular in patients with ARDS. So transpulmonary pressures are very important. And most of you are aware of transpulmonary pressure, but just a few slides, few clinical scenarios to explain transpulmonary pressure. So this is a healthy subject, not on the ventilators, like you and me. At the end of inspiration, alveolar pressure is 0, but due to the action of the respiratory muscles, pleural pressure is -8. So transpulmonary pressure will be 0 minus -8 is 8 centimeters of water. But now in this patient on the ventilator with a stiff chest wall, for instance due to edema or obesity, so in this patient with a stiff chest wall, pleural pressure might be as high as 25 centimeters of water. So if this patient is in controlled mechanical ventilation with a plateau pressure of 30, alveolar pressure might be 30 and transpulmonary pressure might be 30 minus 25 is 5 centimeters of water. And in this case, a patient with relatively healthy lungs on pressure support, the plateau pressure and pressure support might be 10 centimeters of water, but because of the high inspiratory effort of the patient, pleural pressure is really low. For instance, -15. So in this case, transpulmonary pressure is 25. So despite the much lower plateau pressure in this patient, compared to that patient, transpulmonary pressure is higher and there might be more risk of developing villi. So this is just to show you how important the action of the respiratory muscles or patient effort is in the development of villi. So it's quite surprising that so few studies have been published that address this subject. And this study has been touched upon this morning a little bit, but this is a fantastic study, I guess, published in the Blue Journal a bit more than a year ago. And they studied Pendelluft. And Pendelluft is a German word for the movement of gas, in this case in the lungs, without a change in tidal volume. So in this paper they describe this case. This is a man post-CABG surgery, ARDS. And they are measuring changes in tidal volume using electrical impedance tomography. And we're going to address that technique in detail tomorrow. But to me the bottom line is that you can use this technique to track changes in tidal volume within the lung in certain regions of interest. For instance here, zone 1, 2, 3, 4, from non-dependent to dependent areas in the lung. So first, this patient is on controlled mechanical ventilation and muscle relaxants. So what happens? This is airway pressure flow, and this is tidal volume in zone 1, 2, 3, and in zone 4. So at the initiation of a mandatory effort, of course there's an increase in airway pressure, there's an increase in flow, and there's an increase in volume in all 4 regions of interest. But now the same patient is on an assisted mode, so there's a patient effort. Look what happens here, as expected. There's a decrease in airway pressure. And now, if we start at the most dependent part of the lung, there's an increase in tidal volume, but at the same time, in the beginning of inspiration, there's a decrease in tidal volume in zone 1. So that actually means that volume is flowing from zone 1 to zone 4, which is the evidence of Pendelluft. And only in the second part of inspiration, volume decreases in zone 4 and starts to increase in zone 1 and 2. So this is Pendelluft. And this is important And I highly recommend you to read this paper, because what the authors indeed show, that this Pendeluft phenomenon in this part of the lung causes the same stress as if the patient would be ventilated with a tidal volume of 15 ml per kilogram. So they did a similar study in pigs with ARDS, and again, right here, flow, airway pressure, and now esophageal pressure, and again zone 1, 2, 3, 4 as defined by EIT. So look right here, there's an effort by the animal, so a drop in esophageal pressure, and again a distribution of tidal volume, initially to the most non-dependent parts of the lung, and a decrease in the most ventral parts of the lung. And now they start infusing a muscle relaxant right here. And of course, as expected, respiratory drive decreases right here until, after a few breaths, to 0. Controlled ventilation. And at the same time, the Pendeluft volume decreases. So probably less lung injury. And this is, of course, completely consistent by the idea or the study by Papazian published in the New England Journal of Medicine that shows that muscle relaxants actually improve outcome in the early phase of ARDS. But I always had a kind of clinical problem, because we do have patients that are actually recovering from ARDS. After day 5 or 6 on the ventilator, pH is completely normal, but they still have these high tidal volumes, despite a reasonable level of support and despite a reasonable level of sedation. So the problem as a clinician is, what should we do? Even add more sedation, which might adversely affect outcome? Add muscle relaxants again, or just accept this? What we thought, could it be possible to administer a low dose of a muscle relaxant? So there's still activity of the respiratory muscles, but you just try to decrease drive a bit. So that's what we tried in this proof of principle study, and I'm going to show you just some preliminary data. And to be honest, the idea is not completely new. This is a study published 35 years ago in Journal of Physiology by Campbell. And what he did is healthy subjects sitting in a chair with straps, otherwise they would fall off, and infuse low dose, at that time, curare. And they infused it until maximum inspiratory pressure dropped from 100 to approximately 10 centimeters of water. So the patients, healthy subjects, I guess students, were still able to breathe, but with a much lower maximum inspiratory pressure. So that's what we try in our patients. So patients with ARDS, invasive ventilation on an assisted mode, high tidal volume, despite, I'm going to show you later, adequate level of support, and a pH higher than 7.4 D. Deep level of sedation, rest -4, -5, and the patients were equipped with an EDI catheter and esophageal and gastric balloons. So the protocol, and I've simplified it a bit for today. First, patients were switched to low level of pressure support, just to show that even at low support levels, tidal volumes were too high. And then we switched them for 10 minutes to pressure support of 12, because that is a reasonable level of support for these patients, we guessed. Third, patients were switched to NAVA, and the level of support was titrated to resemble the level of support as in 12 of pressure support. Then we started titration with a muscle relaxant, in this case rocuronium, just small boluses up to the point the tidal volume was below 6 ml per kilogram. And then we switched patients again to pressure support of 12 for an hour to demonstrate that we could maintain these low tidal volumes for a longer time. And after that, they went to pressure support for the same level of assist. And actually, step 5 and 6 were randomized. So preliminary data, 8 patients, 62-year, PF ratio of 205, and a PIV of 11. So, and this is just to show you how the protocol works, a representative patient. So right here, tidal volume, dose of rocuronium administered. So this is the lines right here, the amount of rocuronium infusion. So this patient had a tidal volume of around 8 ml per kilogram at 6 of pressure support, and a bit more than 9 ml per kilogram at 12 of pressure support. And right here we started titration, and in a few minutes we were able to reduce the tidal volume to, well, somewhere between 5 and 6 ml per kilogram. Then in the more chronic phase, in the hour afterwards, we were still, with adapting the level of rocuronium, we're still able to maintain this low tidal volume on NAVA or on pressure support. So group data, this is first the data during titration of the muscle relaxant. So this is the EDI. We started out with the EDI of about 18, and at the end of the titration, so about after 5 minutes for the whole group, EDI was around 5 microvolts. So tidal volume on average for the whole group was a little bit higher than 9 ml per kilogram, and we were able to, well, get to a tidal volume below 6 ml per kilogram. So right here, peak transpulmonary pressure, which is important, which is the lung distending pressure, pretty high at the beginning, 26, 27, and we were able to reduce that to around 10 centimeters of water. Of course, with the drop in tidal volume, there's an increase in respiratory rate, as expected here, but as I will show you later, it did not fully compensate for the reduction in minute ventilation. So this is all during the titration. Now what happens in the 2 hours afterwards? All right, here, EDI at the beginning, before administration of muscle relaxants, after titration, and then in the hour afterwards. So we were able to maintain a rather low, at least a lower level of EDI, and the same thing is true for tidal volume. So after this 1 hour, or actually 2 hours, you're able to maintain tidal volume around 6 ml per kilogram by continuous administration of the muscle relaxant. Same thing here for peak transpulmonary pressure. We were able to maintain that as well, around 15 for an hour or longer. So this is the blood gases. Yes, so minute ventilation fell obviously, and this resulted in, well, more or less mild acidosis. So again, these were not the patients with a high respiratory drive due to acidosis. pH was higher than 742 to start out with, and at the end of titration 736, and after 2 hours of ventilation with the low dose rocuronium 733. And this is due to an increase in CO2 in kilopascal and millimeters of mercury right here. So PO2 and PF ratio didn't really change due to the intervention. So the conclusion is, I guess, that by using a low dose, so there's still activity of the respiratory muscles, but by using a low dose of muscle relaxants, we were able to titrate the tidal volume and transpulmonary pressure and perhaps reduce the risk of ventilator-induced lung injury. This at the cost of acidosis in some of our patients. And I have to admit, I mean, the long-term titration of rocuronium is not easy for this patient. This is rather labor-intensive. And what we didn't study, because these patients were heavily sedated, what we didn't study, of course, is what happened to dyspnea sensation. And the other thing we, of course, are unsure about is the long-term effects on the diaphragm. So to conclude, I think I've shown you that it's very important to be aware of the breathing effort of patients in ARDS, in particular on an assisted mode, but because they may have very high transpulmonary pressures, and therefore, and we're going to discuss that in more detail tomorrow, the diaphragm-lung interaction is indeed extremely important. And perhaps, but I'm very careful, perhaps the low dose of muscle relaxants is a future option to reduce the risk of VILI. Thank you.